this amazing woman who was running, which would be our first woman mayor, who's now Mayor Amy Goodwin. So that's a bit of a teaser to the future. So you have this Amy Goodwin running against CrossFit, and CrossFit had no chance. So in order to get a chance, he basically said, you know what, I'm going to run a war against people who use drugs in this city. I'm going to promise in every debate, I'm going to take over the whole debate, and I'm going to say, we will never run again a harm reduction program in the city. And the one that we have, I'm going to crush it and keep it crushed. And that was his sort of, he was like a dragon. He was just throwing this fire everywhere he went. And it made it a much more heated and a much closer race. And he almost won. It was close. He sent out mailers that were like saying, don't vote for this needle lady. Basically, you know, I'm your man. I'm your law and order guy. And through that campaign, our program actually got shut down. Like basically the mayor, who was still the mayor at the time, was like, in order to help my CrossFit guy, I'm gonna basically use my powers as a leader of this city to pressure this program, to buckle this program. And he got the police chief to come out and say to run informants into our own health department. And then he got the police chief to run rules that actually the police chief was allowed to execute rules on the program. And rules included things like, you must show ID to get services. You must be tested every time you come in for all manner of infectious diseases. Must have ID. You must have retractable needles, which are like awful. They just blow your veins. And some other really awful things. And so the program just buckled. And so while CrossFit's not our mayor, Mayor Goodwin is, the program remains shut down. And that was early 2018. And that is just awful. Here in West Virginia, it didn't just affect us. You might have heard Cabell County, a county down the road, they put restrictions on their program, and within a year had over 100 HIV cases. And then another county, their program followed suit and buckled. Another county, Logan County, saw the writing on the wall and put down a preventative ban. So this had ripple effects around the state. A rogue senator, a state senator, was like, whoa, fear and stigma can get votes, can squash programs. And he started to introduce state legislation to stop programs statewide. So this became the epicenter of fear and stigma here in Charleston, West Virginia. And I was just a social work master's student at the time. And I thought I didn't know anything about syringe exchanges. Why are we giving out syringes? You could have actually easily swayed me back then to any kind of opinion. But I quickly started to pick up the research and look at the data. And a lot of politicians actually say this, but they don't mean it when they say it. But I was like, wow, between 2018 and 2019, 1% of our entire county was diagnosed with chronic hepatitis C. The writing was on the wall for the HIV outbreak. And so I'm just a Jewish guy from New York who tends to go where there's pain. And I'd been here already for 7 or 8 years, but I didn't know anything about drug use. I didn't know anything about recovery. I didn't know anything about harm reduction. So everybody knows someone who's, in a 12-step program. So I called up my friend Sarah, who's in a 12-step program, who's amazing. And I was like, isn't this wrong? Should we do something? And she was like, yeah, let's have some community meetings. And so we had a year of community meetings where every month we would come together with 50 people and a huge stack of pizza. There's always pizzas. Dr. Seitz will tell you if Joe's involved in organizing. And we had all kinds of, meetings on the topic of harm reduction, what we do to save lives. But we were really screaming into a void. I mean, to be honest, those meetings were good for building kinship, but not for getting all that much done. At the first month that our mayor was brought into office, our new mayor, we went to her office and we said, with a plan, we wrote a blueprint of what the city could do. A lot of this stuff is not rocket science. And one of them was, restart harm reduction. And she, at the end of that 1 hour plus meeting, she's a wonderful leader, but she's guided by kind of sometimes the low denominator of our city of what was now this blanket of fear and stigma. She looked at our list, she read it, she wrote notes on it. She said, the easiest things on this list will take a year. And there was some pretty easy stuff on that list, like putting naloxone in every city building, basically. And so we sort of heard that and remembered it. And after a year of having these community meetings and not seeing much get done on that list, we ordered some syringes on Amazon and figured out that you can actually get naloxone for $1 a vial, and just started to drive around. And Charleston wears a lot of its pain on its sleeve. And so we could drive literally to the local McDonald's, park, get some French fries, and just connect with people that were in the local park there. And that park behind the McDonald's is an AIDS memorial park, which is where we knew people were actually transmitting HIV. So we went into the park, me and my friend Stacy, and we said, "Hey, could folks use some needles?" And people were like, looked at us like, they looked at this face and this sort of hoodie and random get up, and they actually thought I was a cop. And they're like, "Are you guys cops?" We were like, no, we just thought that someone should do something. And by the next time we came out, they thought we were angels, because no one had done this at that point for over a year. No one had moved a simple 10-cent syringe, a simple $1 of naloxone for a long time. There'd been a real desert. People told us about how they were reusing syringes they found in the bushes, how they'd been using the needles until they broke off in their arms. Of course, they've been resharing and reusing needles, and on, just these lists of nightmares. And we were heartened, but also it's a very haunting work. So we kept going out and we kept giving out more and more stuff, driving into under bridges, driving into, a lot of times it was convenience store gas stations across the city, or this Wendy's or that Wendy's. We have a lot of Wendy's in Charleston. And so it was a terrible thing for my diet. I ate a lot of French fries those first few months of doing street harm reduction. And we saw so many more people as we went, that we could no longer serve all the people that we had made promises to the week before, the couple of days before, because we just have so many more places to go to meet people, because we got people's cell phones and got to know people, got to know people's names, got to know Cora, who'd saved so many lives with naloxone. We really wanted to keep her covered every week. Met Snow and Dee, who were trying to keep a lot of people safe and trying to run a secondary exchange with the supplies that we could give them. So we had to basically tell people to meet us. And we were like, "Hey, we're going to be in this, this Go Stop parking lot, in North Charleston at 8 p.m. Be there, be square." And then there'd be a line, 20, 30, 40 people. We're like, "Whoa, this is getting a lot." And then we would move to a bigger parking lot, like the old Kmart parking lot on the west side. And then we'd see at that point, we were seeing up to 100, 150 people. We started running HIV tests. The first time we set up HIV tests, there was a positive, which is unheard of, even in like New York or New Jersey. The second time, maybe a negative. The third time, a positive. Fourth time, 2 positives. I mean, these numbers just started cascading in because no one really been doing testing. And these are pandemic months. So it was all just kind of risky. Sometimes we would give out, at the first month of the pandemic, we were going out. We didn't know what this virus really meant. We just knew people were dying. We gave out cupcakes that a local pharmacist made, and we didn't know if it would make people sick, because I'd handle a cupcake or give it to someone our hands would touch or something. So we put the cupcakes on the gravel of the parking lot, these gas station parking lots. We're like, "I know this is weird, but these cupcakes are for you." And that's how we moved stuff for months and months. And eventually we started to hear about these amazing ways that people were using the naloxone. It got up to, and still is, at an average amount that people are using the naloxone matches our local EMS for use of naloxone for opioid saves. So we're now at 2 saves a day for an entire year. So 1 save every sunset, 1 save every sunrise, for an entire year from community overdose reversals, largely from these $1 naloxone vials, of which we distributed over 10,000. And it's been, so here we are. And I'll just wrap by saying we inspired a lot of conversations. We inspired a lot of friends and allies, and we also inspired a lot of jerks and folks who like that CrossFit guy, really punch down on people who use drugs, especially if you're going to earn them political points. So now we are facing down a city ordinance that could crush us. That'll go up for vote on Monday, and both our houses of legislature, so the West Virginia House of Delegates, the West Virginia Senate, have passed a bill that would make it a $10,000 fine per violation to do what we're doing, in which is best practice. In other words, to give someone a syringe without asking them for an ID, which we're never going to turn anyone away. That's how you get death and HIV. So that's the state law that's on the governor's desk right now. These are heavy times. Most of us are feeling really punched up, even as we're now moving back to this model of going out at night after sunset, and because our big events caught so much attention and blowback that we've had to turn them off and haven't done one for 3 weeks. So we're in the thick of it, and I'm excited to hear the other speakers, and I'd be happy to field questions about that story. Yeah. And if you want me to keep rambling, I can, but I just figured there's more.
Sorry, I'm still awkward with the Zoom. And Joe, I have a couple ideas that I want to run by you as far as ways that you can address, especially the fine. Like with the story that you shared just gave me chills, and I have a couple ideas that can maybe help your program. But until then, I'm going to go ahead and move on to the next speaker, though. Sorry. So Dr. Chris Schutz has earned his PhD from the University of Georgia. He's currently a professor of history at Tennessee Wesleyan University. He's the author of Jackie Robinson, An Integrative Life, and is currently completing a manuscript on the Charlotte Three, a 1972 court case of Black Power activists in Charlotte, North Carolina. From 1986 to 1987, he worked at the AIDS Project of the East Bay in Oklahoma, California, and his talk is entitled Reflections from a Year in AIDS Pandemic in Oakland. Thank you, Dr. Schutz.
Thank you, Dr. Prairie. First, a bit of a context and then a disclaimer. So I graduated with my undergraduate degree, went into a religious volunteer program called the Jesuit Volunteer Corps, where I served 2 years. It's simply a program where you work for a monthly stipend, get room and board, and it's a good deal basically for these nonprofit agencies who would get a college-educated person. This was my second year when I worked at the AIDS Project at the East Bay, which I'll talk about in a moment here. A disclaimer: I was mostly the food pantry coordinator. So there were certainly other people whom I worked with who were more on the front lines than me during this AIDS epidemic. This program located in Oakland, California in the East Bay. Of course, when the epidemic begins, it is largely perceived as a gay male disease. And essentially a kind of white gay male disease, really. But the East Bay of the Bay Area is far more ethnically diverse. Oakland in particular has a long history of Black leadership. It's the site where the Black Panther Party first emerged. And so it's a much more diverse community than, say, San Francisco, a wealthier city across the Bay. And so really early on, before, say, the city of San Francisco, whom we were having a lot of contact with, they became very much an early flashpoint for the epidemic. But we were seeing far more people of color, for example, at our agency and dealing with those issues earlier than others might have been. Vast majority. So I'm there in 1986 and 1987. And I'm going to give a bit of background here on the epidemic for those who might not know. In April of 1980, a San Francisco man is admitted into the hospital with Kaposi's sarcoma. This was one of the opportunistic infections. It was a kind of skin disease, or I think it might have been classified as a cancer, actually. It was extremely rare, except for those folks with HIV. So it's puzzling doctors and whatnot. This person turns out to be retroactively identified as the first AIDS case in the United States. By May of 1981, a gay newspaper in New York is we get the first journalistic report about this cluster of cases with New York City men, in that case, with a strange pneumonia. This was pneumocystis pneumonia, or PCP. That was another one of those rare opportunistic infections that was plaguing people with HIV. By 1982, the summer of 82, the term AIDS is first really even being used. And that replaced, interestingly enough, GRID, which was the term used prior to that, which was an acronym for gay-related immune deficiency, which says a great deal about the perception early on here. But by now, they're beginning to see cases of people beyond simply those white gay males. And so they are starting to stretch that term now. By the fall of 1983, the CDC is identifying the major routes of transmission and declaring that casual contact does not spread the disease. By 1985, you get the first sort of clear research indicating that's widely accepted now, at least in the medical community, that it is mostly being passed by blood contagion. It is not until 1987 that you get the first presidential announcement. Ronald Reagan, very slow to respond to this, and I'll talk about some of the sort of public perceptions of disease and how that affected government responses. But despite the fact by 85 and even by 83, we're beginning to get evidence of that casual contact, for example, is not spreading it. A lot of doubt lingered with many people, and a lot of fear, even in my time in 86 and 87, in the communities about even things. I remember toilet seats being one thing that people were terribly fearful of that could spread it, or even shaking hands. We had this wonderfully gregarious postal deliverer, this middle-aged woman who would come in and chat with us. But whenever she was gone or sick, you could tell right away, because a hand would the door would open to our office, and you'd simply see a forearm dropping the mail. This was a mail carrier, obviously terrified of getting AIDS by giving us our letters. Really important to, and I think it's really kind of hard to describe the, unless you're an old codger like me who can remember this, really the profound homophobia and transphobia of that period. That was a profound effect, certainly, on the public perception and the response to the disease. The evangelical leader, Jerry Falwell, for example, was saying that AIDS is the wrath of God upon homosexuals. And the communications director for President Reagan at that time, Pat Buchanan, argued that AIDS is nature's revenge on gay men. So that was a profound effect, and that lingered for many years until the non-LGBTQ community begins to wake up to how it can be spread beyond simply these gay men. The first knowledge that begins to seep in is IV drug users, something Joe Solomon just talked about, still an issue today, and prostitutes. Now, that is not a list of gay men, prostitutes, IV drug users. That is not a list that is going to elicit a quick response from politicians and from the wider community. It's really a kind of list, these first people most struck by the epidemic, surely in which there will be no response. And so that was a profound effect on the slow response to dealing with all of this. For the gay men that we were mostly seeing, particularly at the beginning of my time there, important to note as well, there was a double burden really. This being a time of deep homophobia and transphobia, we have to remember that many of these young men are carrying the double burden of getting sick, telling their families, and this might be the first time that they are coming out of the closet, to tell their families both that they are gay and the reception that might be severe against that, and that they may be dying. So just a heavy, heavy toll on the people we were working with. And of course, all sorts of restrictions in place against partners of these gay men who were going into the hospital. They would be rejected from visiting because they weren't defined as family, and we were constantly trying to juggle that and deal with that. We did have a kind of quasi-secret network of what I might call friendly health officials who we would call upon privately, working in those hospitals, social workers, nurses, doctors that we knew could kind of work around the edges and perhaps work around the rules. And we would call them kind of surreptitiously and to see what could be done. This is a time too where the HIV disease was really divided into three areas. There were those who came up HIV positive, and now of course we just talk about HIV related disease, but those folks were not counted anywhere it was simply, do you have AIDS or not? So you might have all kinds of health complications from having HIV in your system, but not receive any attention or health benefits or anything of that kind. There were those who had gotten the AIDS diagnosis, and there was a kind of list of those opportunistic infections that would count towards you receiving that AIDS diagnosis. The one that was, of course, the one we always worried about was that pneumocystis pneumonia, PCP, and that was sort of dreadful, taking people down. And some survived that once, maybe twice, and we always worried about a cough on somebody who had it at least once, often not surviving. There was a third category, though, at this time called ARC, R-A-R-C, which stood for AIDS-related complex. And these were people who had another list that the government established of certain opportunistic infections, but did not count towards the AIDS column. And the government would at times shift that back and forth. And I remember talking to folks who said that they, went to bed one night and they had AIDS. They woke up the next morning and the government tells them they have ARC. And the significance of that and the suspicion around that was, at that time, this ARC diagnosis did not entitle you to certain government benefits like Medicaid, for example. And there was always this suspicion that they were shifting those definitions around as the epidemic expanded to limit how much the government actually was going to help folks. No cure, obviously, at that time, and not even really many decent halfway treatments to handle this. We had our folks scrambling for anything they could grab, and they would be talking to one another. I remember one thing was vitamin C, people taking a ton of vitamin C. And there was just sort of almost an urban legend that might help, and of course, ready to try anything given what was happening. AZT was just starting to be used by the end of my time there. And my understanding is AZT is part of that cocktail that is now used to handle the HIV disease, but it was being used in much heavier doses at that time, and it was just severely impacting people's systems. So it seemed to have some effect on the T cells and whatnot that people were struggling with, but it could be very, very harsh on the system. one of my coworkers called it AZT poisoning, when some people began to take AZT and saw their health actually decline because of the effects of that. So it's kind of irony that AZT now being used as certainly a helpful commodity for this cocktail now being used in a much milder dose, as I understand it. As some mild treatments begin to be somewhat effective prolonging people's lives, we began to watch other things happening. So people began getting certain opportunistic infections that they weren't getting before. And I particularly remember by the end of my time in 1987, one thing that was starting to happen was dementia. So the virus, it seemed, could attack the brain tissue. Before that, so many people were dying so early that it didn't really seemingly, the HIV virus, have much chance to really target the brain well enough that you began to see those symptoms. But that was starting to happen by the end of my time there. And one man I remember sort of turning violent at my door, who was suffering from this dementia. I have really been enjoying what we've been doing on this symposium, and I got to thinking more and more. This is a conversation I had with Dr. Seitz, the co-host of this symposium, about a student paper that was yesterday about the yellow fever epidemic in late 19th century Memphis. And I'm sure I'm going to butcher some of the details of this paper, but I was fascinated by his depiction of this yellow fever sweeping through Memphis in the late 19th century, and how the middle-class whites and upper-class whites who could afford to do so are fleeing the city. And what's left behind is the African-American population and a small number of immigrants who were working class, who could not escape and were being left behind. But in this sort of sequestered, diseased city begins to emerge, particularly among Black Memphians, it seemed, sort of stepping into the fray and trying to run sort of almost public health and police forces to try to manage whatever they could. And I found that fascinating insofar as one of the things that we've been exploring in this symposium, and one of the things that's been much discussed even about COVID-19, is how the epidemic has exposed these social divisions that we have, racial divisions, economic divisions. And that was evident in this yellow fever epidemic in Memphis as well. But these folks left behind in Memphis dying of this yellow fever also engaged, sort of grabbing a small amount of power for themselves in the midst of that chaos. And there's certain things that reminded me about my time in the AIDS epidemic in those earlier years. In this case, certainly it is the LGBTQ community that is the disenfranchised one here. And they are the ones stepping into the breach, and literally with their bodies, of course. And it reminded me of the kind of medieval origins of that phrase, of the castle under siege and putting your body in the way to be sure it doesn't fall. And this reminded me a bit of we used to have this support group at the AIDS Project just for people to kind of try to bring out their emotions. And I remember one of those Friday support groups gathering and talking about people joking about how this is, what has been endured here is like being a war veteran. And years from now, we'll gather like old war veterans do at some bar and tell these old war stories. But these folks, these LGBTQ folks who I work with, and the some hundred volunteers or so, who there may have been some cisgender straight folk in that group of volunteers. I don't know of any. And they are the ones sort of left behind like these Black Memphians. stepping into that breach here. And, you know, there's been some discussion in recent years about the rapid Supreme Court decision in 2015, which legalized gay marriage, and how quickly it seemed to turn, society seemed to turn. And I will count myself in that group that was sort of surprised how quickly that seemed to have happened. But there are really some antecedents, certainly all along the way. And as I think about that long road, this is not an original point, but I think one that's not discussed enough. These LGBTQ folk who stepped into this breach of the epidemic, they are the ones who cared for, first of all, the gay men, but then lingered. They are the ones who remained and put their bodies on the line during this epidemic. And I don't think that was forgotten, particularly as both, perhaps there is that one gay uncle that you think so well of, and despite perhaps your homophobia, you do remember those LGBTQ hands who cared for him in his last days. And then as the epidemic did seem to progress more and more into the straight community, it is still really these LGBTQ folk who are the veterans, who know what they're doing and are still doing the work. So it first takes enough of these straight people to fall to the epidemic before you much later get the straight people stepping forward to work on this. And so I do think there was something really powerful about the heroism exercised by those folk that was not forgotten and did help pave the way for what comes later. And so in this desperately difficult work that they were doing, in a way, sort of laying a foundation for a kind of power or recognition in American society that they can use later, a little bit like those Black Memphians in that yellow fever epidemic. Certainly, being present in that castle under siege shaped and changed me. I was surrounded by these amazing people, both the staff and the volunteers. And I, as an old codger, grew up in the 60s and 70s with a far more restrictive view, certainly, of masculinity. When I worked there, everyone assumed, of course, that I was gay. And I, of course, took that in stride, got used to that, and you begin sort of living in that culture. And it did give me a far more expansive view, even of manhood itself, more emotion, more open compassion. Two older gay men in particular took me under their wing. And I know in a way they were kind of teaching me during my time there. There was a moment I remember of a young man who was a volunteer, and this is towards the end of my time there, and we were planning a fundraiser, and we were talking, where is this fundraiser going to be held? Who can we call upon? And the conversation moved along enough to where I finally had to tell him that, because we were talking quite a bit about gay bars being a good place to go to, and I finally had to tell him, I'm straight, so I don't really know as much as I'd like about these gay bars and what are the more prominent ones. I'm happy to go there, happy to participate, but I'm not the best source of information about where they are. And I'll never forget, he just sort of clasped his hands to his head and was shocked that I could be straight, and also said, he was also embarrassed because he'd been hitting on me for a week, which frankly I hadn't even noticed. Certainly assured him that was fine. But I remember him saying, not just because I was working there I must be straight, but that my demeanor did not seem to be straight. And by the end of that time there, I could take that in as frankly one of the greatest compliments I've had, to sort of understand what he was trying to tell me there. So a powerful change for me, certainly. And this reminds me too, as a historian of the civil rights movement, there's this phrase that's sometimes used of the activists, ordinary people doing extraordinary things. And there's some truth in that as far as it goes, of these disenfranchised folk who turn the society radically upside down. But I teach a civil rights course, and by the end of that, I'm trying to get the students to understand these are not ordinary people, that you can see from the beginning how extraordinary they are in the biographies we're reading. And neither were these AIDS workers. There's a quote I read that I wanted to just, a short one I wanted to read from a renowned Mississippi activist who had been exposed to the Student Nonviolent Coordinating Committee workers, this legendary group of young people who came into Mississippi during the movement. And Anzie Moore will later himself become a major activist. And he described seeing these Student Nonviolent Coordinating Committee activists and how that changed him, saying when an individual stood at a courthouse, like the courthouse in Greenwood and Greenville, and you watch tiny figures of these workers standing, these civil rights activists, standing against a huge column, against white triggermen and drivers and lookout men, riding in automobiles with automatic guns, how they stood, how gladly they got in front of that line, those leaders, and went to jail. It didn't seem to bother him. It was an awakening for me. I read that in class sometimes, and I'm always thinking of these AIDS workers, and just my time there, what an enormous gift it was to just be able to be in the company of people like that during that short amount of time. Thank you for your time and attention.
Thank you for that. And both yours and Mr. Solomon's talks reminded me just of the innovation that comes with work in addressing stigma, and a tired few. You talked about the networks of like doctors that were willing to do this type of work, and also just with like Mr. Solomon and the stuff that he does with just going out into the community and meeting people where they are. And I just really admire that work and bringing people together for that. And actually, our next speaker was just able to join us. So I'm going to go ahead and introduce our next speaker. Dr. Kristi Stringer is a postdoctoral research scientist in the social intervention group within the School of Social Work at Columbia University, and fellow in Columbia's T32 training program in criminal justice, HIV and substance abuse, and lifespan Brown Criminal Justice Research Training Program at Brown University. Dr. Stringer has a decade of experience conducting research focused on identifying and addressing health-related stigma experienced by vulnerable populations. Her program of research primarily involves the application of qualitative and mixed methods to elucidate and intervene upon the mechanisms through which stigma impacts health outcomes for three intersecting and interrelated populations: people with substance abuse disorders, people living with HIV, and people impacted with the criminal justice system. Her talk is entitled Understanding and Combating HIV-Related Stigma in Healthcare Settings. And I'm very proud and honored to introduce Dr. Kristi Stringer.
Hi, sorry I'm joining late. I thought it started at 6. I apologize.
Yeah. Oh, because you're 6 Central Time.
Yeah,
sorry.
Yeah, I'm on Central, and I did not think to make that connection, but I'm here.
It's okay. You made it.
Here.
It's perfect.
I'm here.
Yes.
All right, and I'll go ahead and share my screen. This one. Can you, well, how about now?
Yes, perfect.
Okay, perfect. Now I need to, sorry, if I was on here earlier, I could have had all of this.
You're fine.
I'm here now. Okay. All right, so as Dr. Perry mentioned, my name is Kristi Stringer, and I'm going to talk to you guys today about HIV-related stigma in healthcare settings. And I am a postdoc at the at Columbia University and the Global Health Research Center of Central Asia, as well as at Brown University in the Center for Health and Justice Transformation. And just to give you a little bit about my background and how I approach this work, I study the intersections of substance use related stigma, reproductive related stigma, HIV and STIs, and as well as stigma related to criminal justice involvement. And I look at how those stigmas impact access, quality, and utilization of various care services. Recently, I've gotten more into the public policy arena, and generally my work focuses on the US Deep South as well as Central Asia, and specifically in Kazakhstan. So at the end of this session today, I want you guys to be able to define stigma and its dimensions, explain how HIV and intersectional stigma impact treatment behaviors, and identify a handful of intervention approaches and intervention tools to reduce stigma in the healthcare setting. So defining stigma. We typically start with Erving Goffman's definition of stigma, which he stated was an attribute that is deeply discredited, which reduces a person from a whole and usual person to a tainted or discounted one. However, I prefer this definition that has a little more humanity behind it, and it's a little less sterilized. So I've added to the front half of that stigma is a degrading and debasing attitude of society that discredits a person or a group because of an attribute, whether it's illness, deformity, color, race, nationality, religion, citizenship status, etc. And then finish it off with Goffman's definition that causes one to lose social value. And so when we talk about stigma and the types of stigma, we talk about anticipated stigma, which is the fear that you will experience stigma. It doesn't really matter if it actually happens, just the fear that it might happen often significantly impacts people's healthcare utilization and their utilization of their support systems. There's community stigma or normative stigma, which is just an awareness of how the community views a person with the attribute that the stigmatized person is holding. There's experienced or enacted stigma, which this can be broken down into discrimination, which are those things that lie within the legal purview. So that, protected statuses like housing discrimination is discrimination, but also just prejudice that maybe doesn't fall into the legal purview, which may be social isolation, things that do not fall under legal terms. And then there's internalized or self-stigma, which can often be amplified by these other dimensions of stigma. So stigma is a complex phenomenon, and it happens all around the world. It persists globally, and it persists locally. So the picture there on the right is with one of our populations in Kenya. This is one of their signs that they've put up to combat stigma there. And then, oh, that was on your left. And then on your right is a photo of a local church here in Birmingham, Alabama. And one of the signs, this preacher is known for his attention grabbing signs, but this one's been up a time or two. So what do we know about the effects of HIV related stigma? We know that persons affected by HIV, they're going to have frequent contact with healthcare providers, and stigma significantly impacts that contact, the patient-provider relationship, as well as testing, PrEP utilization, linkage to care after testing positive, adherence and retention in care, and getting other kinds of medical care that they need. And of course, it can impact the quality of the patient-provider relationship and the quality of the care that is provided. And when we talk about HIV-related stigma, when we talk about HIV in general, we have key populations who are at a higher risk for contracting HIV, and that's people who inject drugs, people, men who have sex with men, people who engage in sex work, and the partners of all of them. So people who are living with HIV often are subject to other types of stigmas as well. Of course, we also know that the HIV epidemic impacts racial and ethnic minorities at a greater extent than it does others. So there's the racism or race-related stigma on top of that. So the picture here in the background, you guys are the first one to see this. My boss hasn't even seen it yet. I've been working on it today. So some of my work, I mentioned I do some work in Kazakhstan, and in Kazakhstan, Kazakhstan and East Europe are the only places, or Central Asia in general, and East Europe are the only places that the HIV epidemic is continuing to rise. And the reason is because they lie right along the major drug trafficking routes. So heroin that is harvested in Afghanistan, it's estimated 120 tons go through Kazakhstan every year. And about 12 tons stay in Kazakhstan each year. And so there's a high population of intravenous drug use, which is what you see there for that IDU. And the intravenous drug use is driving the HIV related epidemic. So this picture is actually a visual representation of the types of stigma that our populations reported experiencing. So this was 600 people who inject drugs who are living with HIV in Kazakhstan. And I want to say right at 50% reported HIV related stigma. And then there were these intersectional stigmas with sex work, sexual orientation, incarceration, other alcohol and drug use. And I think the one up at the top there is citizenship status. So I just thought this was a good visual representation of the intersections of stigma that are faced by some populations living with HIV. Here in the US, we have a lot of qualitative work on intersectional stigma. We haven't been too successful in measuring it quantitatively. But I pulled this quote out from a friend's publication to talk about how complex intersectional stigma can be. So she says, all my life, I've always wondered why people discriminate against me for. Is it because I'm Black? Is it because I'm biracial? I never knew if they were discriminating against me because I'm living with HIV or because I was a woman. Honestly, I don't really know. It's just like someone insulted me. And I saw another quote recently where I think it was a human rights and dignity quote where they said, you know, dignity is one of those things that we have a hard time defining, but everyone knows when our dignity has been violated. And I think that that's the case with intersectional stigma. We may not be able to pinpoint exactly what aspect is drawing the stigma, but we know that it's there. And so how does stigma, this is just a quick framework, I already went over kind of how it impacts care for people living with HIV, but this is just a framework for how it does that, the mechanisms through which it does that. Of course, it has your direct effects on health, but then it also acts through psychosocial mechanisms and behaviors, which then also lead to poor health outcomes. So why is it important that we talk about stigma in healthcare settings? So fears of stigma in healthcare settings often discourage people from all of the things that we discussed earlier, and really limiting engagement in care, retention in care. And we do know that these impacts are greater for people of color here in the US. So that has a lot to do with the intersections. And so this is Rebecca, and Rebecca talks about the day that she gave birth and her schedule. Her C-section was scheduled for 7 a.m. or no, I'm sorry, it was scheduled for 8 a.m. And at 7 a.m., she got the news that she had been diagnosed with HIV, and 8 a.m. rolled past 9, 10, 11. And she says, you know, once they found out that I had HIV, nobody wanted to do my C-section. And now every time I go to the hospital or to the doctor, I have a panic attack. That feeling of being treated like I'm untouchable comes back. And so it really, I like these personal stories that really drive home the human cost and the real impact of HIV related stigma. And you can see there on the top of her posters, it says, I hate all hospitals and all doctors. And that was a result of the stigma that she experienced in healthcare settings. So fears and experiences of stigma in a healthcare setting often leads to internalized stigma, particularly, you know, when stigma is originating or exacerbating at the very place that you're supposed to be getting compassionate care. It really can erode the trust in the healthcare system, as you saw with Rebecca's story. And we've already covered that. I'm sorry. I tend to get ahead of myself sometimes. So when we're talking about stigma and discrimination in the healthcare environment, we use this framework to identify targets for intervention. So this helps us to generate a research focus by really categorizing things. So we talk about actionable drivers, which are individual level factors that negatively influence stigma. So a lack of awareness of stigma, lack of the consequences of stigma, fear of HIV infection is a big one. I apologize for any barking. And just general judgments about moral character. So these would be at the individual healthcare provider level. And then we have actionable facilitators. And facilitators can be positive or they can be negative. And so, for example, a lack of post-exposure prophylaxis may heighten fear of HIV infection. So we would call that a facilitators. On the other hand, it could be positive in that if you have them, it could reduce the fear. And then, of course, anti-discrimination policies and the enforcement of policies. And the manifestations are, the actual behaviors, how it plays out in the healthcare environment. And then we've already covered outcomes. And I just want to give you guys a few examples, and I hope someone's keeping up with the time. Do I have 20 minutes? Is that correct, Tara?
Yes.
So I have 7 more minutes.
Okay.
All right, so I'm actually going to skip through some of these a little bit faster.
No worries.
This is some of the work that we did in the U.S. This was the first study that had been done in the U.S. in the ART era. Which is why I pointed out that HIV stigma is local as well as international. I think sometimes we have a tendency to look out there, especially when it comes to things that maybe need improvement, rather than here. And so we did find, some blame, some moral judgment among healthcare workers here in the Deep South. And we did end up developing an intervention. So when we go in here and measure stigma, I partner with healthcare environments. I can't go in there and say, I'm just coming in here to tell you guys all the things you're doing wrong. I come in there to identify opportunities for improvement, and then I help them to improve it. So with my dissertation work, I looked at HIV-related stigma and substance use stigma for people living with HIV who use drugs. And what was interesting with this one was that HIV stigma did not predict retention in care or medication adherence, which is opposite of almost everything that you found, but through the quality, or that we know through research, but through the qualitative findings, participants reported that because they went to an HIV clinic, they didn't experience a lot of HIV stigma there, but they did experience drug use stigma there, and that limited their doctors' negative judgments, limited their willingness to communicate honestly with their doctors about the things that were keeping them from taking their meds. Because if their doctor's just going to say, well, stop doing drugs, that's not very helpful. And they would avoid talking to the doctor about those difficulties. So these two, I'm going to speed through. So this is from Kazakhstan. This is very recent data here, but you can see here that there is blame for HIV infection. Most people don't care if they infect others. And there was a pretty high concern about contracting HIV from simply touching a patient's clothing or from dressing the wounds of someone living with HIV. So those were the drivers that we identified there. There are some great things going on here too, is that, if you take a quick look here, there are procedures and protocols that protect people living with HIV. But the 30 and the 37% there is that there may be procedures and protocol, but the providers are not going to get in trouble if they don't follow them. So there was a lack of enforcement. And then the manifestations, this is just what the providers reported. I have a lot more data from people who were receiving care at these same clinics. And And you can imagine if 60% reported wearing double gloves or using some other special measure, how many are not reporting those. So these are just some of the manifestations that we found. And so we found stigma, we found the drivers, we found the facilitators. And so what are we going to do about it? So there are really three key aspects of any stigma reduction intervention. One is that you address those immediately actionable drivers. The second one is that you create partnerships between the people living with HIV and opinion leaders within the healthcare setting. And you really want to put the affected groups at the center of the response. And so I always, if someone asks me to tell them in 20 minutes how to fix them, how to fix stigma in a healthcare setting, I point them towards the work of HPP, the Health Policy Project. And they do have 3 documents readily available. They have a training guide for facilitators of stigma interventions. They have an assessment tool to identify the drivers, facilitators, and manifestations. And then they have some outcome measurements for sustainability. So that's freely available on the HPP website. And I think I'm right on time. So just some examples here of interventions. Of course, interventions are intersectional and they are also multi-level. There are a lot of actors. You have the stigmatized, you have the stigmatizers. And so just a few example interventions that work with healthcare workers. You could look at Nyla Blade 2019. That was a blended training. So there, some of it was done in person in workshops, and then some of it was done on a tablet. There are interventions that work with people living with HIV or community members. There are some great examples of interventions for African American women, for faith-based organizations, group and individual interventions. I try to intervene at the system level because I don't feel like the onus should be on the stigmatized person, when really, if we can stop people from being stigmatizing to begin with, they won't need to learn to cope with it. But it is important to know how to cope with it. And then there are interventions that work with both. One would be the Use 2009 intervention that you can look up there. And then we adapted that same intervention and called it the Fresh intervention. And we used it here in Mississippi and Alabama. And that's available on the Mississippi, Alabama training website. It's free for use, and it brings together people living with HIV and providers using those key strategies discussed. And that's it.
Thank you so much, Kristi. I'm glad that you're able to join us, and thank you for the work that you do. And now I'm going to open the floor up to questions.
See, I see something in the chat.
Okay, yeah, so it looks like it might be maybe a comment. It says from Dr. Mulhite, thank you to all speakers for your work with stigmatized populations. A common thread between the HIV epidemic, other epidemics, and the current pandemic seems to be the general lack of empathy for others until individuals are affected. And so the question is, have any of the speakers seen examples of how to mobilize people to care for others in time of crisis, short of being directly affected?
Yes, so I recommend when talking about, and I think you hit it spot on, it's a lot of what's underlying stigma is a lack of empathy. And there really are some good reflection exercises to get people, like reflexivity, to get people to really think about their values. So we'll have them do some value exercises to really define, and ultimately everyone values, other humans for the most part. Ultimately, everyone does have a fundamental value for other people, but it's the empathy that gets lost. And there's also some compassion burnout, compassion fatigue. Mm-hmm. We see that a lot with opioid use disorder. And I think we're probably seeing it with the current epidemic as well. It's like, we've been changing our behavior long enough. We're tired of it.
Yeah. Okay, thank you. Joe, did you have a response?
I think it's really hard to build empathy, to build love out of, an empty cloth. I think there's a lot of opportunity for building fear. I think that one way that we get respect is by using fear. I think the second speaker, Chris, spoke really eloquently about how so many of the rights of folks living with HIV were not granted. They were earned and fought tooth and nail. I mean, ACT UP organizers from both coasts showed remarkable courage. One group shut down a church in New York, like where a cardinal was being really homophobic, to shut the church down. And that sent a message to the church that it's not okay to be homophobic. Dr. Stringer, I think the muting.
Okay.
Echo. And Yadishmata, and I remember when watching the documentary How to Survive a Plague, which I wasn't there, of course, but I mean, it's just left such an imprint where those activists converged on DC to demand a cure, and they took the ashes of their lost loved ones and sprinkled them on the White House lawn. I mean, combining mourning and loss and courage. And they didn't host a workshop. They didn't have, a zine about how to change your heart and mind. They just got really loud. And I think that is a counter path to earning the kind of respect and human rights that all these groups deserve.
Thank you. And Dr. Schutz?
Well, I don't know that I got a good answer to the question. I think the thing about AIDS, at least in the mid 80s, was there seemed to be no cure whatsoever, not even very good treatment whatsoever. So, it's not even a matter of getting empathy. It's a matter of people overcoming just their dreaded fear of, I step into this and I'm dead, So in that respect, I think it's quite different from COVID. We have good reasons to be fearful and cautious about COVID, but the vast majority of people exposed are living, although with some long-term consequences. And so obviously AIDS has evolved, but just speaking to the time period I was in, I mean, it just seemed like a sheer death sentence. And so while medical authorities are trying to assure you that casual contact and so forth doesn't affect it, the thought that they could somehow be wrong or something might slip up if I'm exposed, the consequences seem to be direct to people in that time period in a way that they're thankfully not anymore.
Well, I'll tell you to kind of bounce off of that and to the next question that is in the chat. My participants for my dissertation research, we talked a lot about comparing drug use stigma versus HIV stigma. And it's not so much that HIV isn't as stigmatized. There's still a lot of stigma with it, but it's not visible, and it's not considered, deadly. It's not a death sentence when you get it. And I do think that makes a difference. And my participants explained, with all the medicines these days, that no one knows that they're living with HIV unless they tell them, whereas their addiction tended to have visible consequences.
Thank you. And so the question that Kristi was speaking to was from Dr. Morgan, a question for the panel. HIV as a pandemic seems to be quite different from COVID-19 in that there seems to be a little more social judgment stigma attached to contracting the disease. COVID is almost invisible as a disease in a way that seems to present a different set of problems. Am I misunderstanding the relationship between the diseases and how we have responded to them?
So there are, I think it's 7 aspects that kind of decide how stigmatizing something's going to be. And that's, peril, blame, worse, it's Jones et al. And, you're hitting on all of those things. So they're all different aspects of the same thing. So if we look across all stigmatized conditions, you can rank each of them on, how deadly is it? How contagious is it? How much is it blameworthy? And so it's almost impossible to compare anything directly because they all have these varying levels. But the ones that are more perilous, so that you're more likely to die from and quickly, and the ones that you are blamed for contracting tend to be more stigmatizing than the others.
Thank you. Any other comments?
Yeah, I think, I'm sorry, Jody, do you want to go?
No, go for it.
I think Dr. Morgan makes a good point. I do think there's a distinction. I'm sure as he well knows, there are some mild markers, I think, of COVID still. We're told, for example, obesity can be a cause, and there's even the Latinx immigrant communities that are forced to be in smaller confines because the families are piled into whatever they can afford into those small homes and so forth. And so I think there are some edges of social stigma that get attached to one's susceptibility even to COVID. But I do think there is a pretty strong distinction there. And, I tried to make that point when I was talking, and I think it just can't be overstated. I mean, when AIDS is beginning, and again, your list is IV drug users, prostitutes, gay men. I mean, let them all go was sort of the social attitude.
Unfortunately, IV drug users are still a let them go population. That's why I focus on those.
And Joe, did you have a response before we move on to the next question?
I did have one. So I think the other speakers were really insightful about why COVID doesn't have a lot of the stigmas around it. But I think it's a great opportunity for showing what a healthcare response can look like if you got rid of stigma.
Yeah.
So I don't know about y'all, but like when I see my health department set up a huge, massive tent where they're doing thousands of vaccines, there's a part of me that cries inside because I know that they're completely dropping the ball on the HIV response. When I see them send out a press release today that one of their staffers got COVID, I'm like, okay, that's a good press release, but where's the press release telling our governor to veto that HIV bill? That anti-harm reduction bill, which is an HIV spreader. So watching that, I think, if we leverage the moment right in the years ahead, we can use this as like, why can't this look like that? And that's partly why my friend got me this mask, which for those that are watching the video, it says, "This is harm reduction." And I pretty much wear it everywhere I go. And I always think people are looking at me funny, but they're just reading what's on my face. It's from the National Harm Reduction Coalition.
I like it.
Yeah. And then, and one way that I address stigma, I came up as a climate activist, and so that was a decade of climate denial until California and Australia were always on fire, and so how do we deal with that kind of denial of humanity, denial of a crisis? Is that I'm dumb. I don't know how to write good arguments. I don't know how to write, how to do my talking points during Thanksgiving. So what I always try to do, because I'm terrible at that stuff, is get people's feet in where they need to go so that their hearts will follow. So whenever we have an epic health fair, literally the days before, I'm Facebooking every pastor, every minister, every nurse who I think might be on the fence, anyone I can muster, anyone who's won an award for being a good citizen or whatever, be like, can you just come to this thing? I ain't trying to sell you on harm reduction. And then when they come, I put this in their hand and I say, can you help us give out naloxone? And in this, are those vials we talked about earlier. And in this are scary syringes, scary. Oh my gosh, this is so scary. And because you need those syringes to administer intramuscular naloxone. And this is the 50th year that the FDA has approved this kind of medicine. Scary stuff. And so like we put this in people's hands, and something radical happens. People that were like, I don't know, giving out needles, something, they're like, when's the next event? When can I join you? And so that's been helpful.
I published a commentary recently about, so harm reduction is my passion as well. The reason I got into HIV work was because at the time I wanted to study HIV or drug-related stigma. No one would give me money for it unless I connected it to another stigmatized population. But what has been interesting, and I released a commentary recently about it, is COVID has allowed us to overcome some structural stigma that we were told we could never overcome. The making at home initiation of medications for opioid use disorder, take home medications for most people on methadone. These are things that we had been told for decades. We've been screaming, change this, change. Oh, we can't change it. That would just be too bad. And then COVID put us in a situation where we had to change it. And I know that there are a lot of people that are seizing this moment to get the data, to make the argument so that when COVID goes away, we can keep, the reduced structural stigma for opioid use disorder.
Thank you. And so we have another question, and this is to Joe. So it's from Dr. Seitz. Dr. Schutz mentioned the truism that disease reveals the underlying power dynamics and the social realities of a community. I'm curious what Joe Solomon thinks the opioid epidemic in Charleston reveals about that community, maybe good and bad.
I bet the other speakers have insights on this too. We're asked a lot by journalists, Mother Jones, New York Times, Washington Post, how come in Charleston, like, you seem so incapable of acting on this issue and in the state? Like, how come there's such anger and outrage and fear around dealing with this? And they can't make sense of it. And I think Appalachians, we get it. Like, we've been punching down on our poor people for decades and centuries. I mean, our states were pretty much founded as extraction colonies. That's the jam of how we got started. And so it's no wonder that in the state that has some of the most coal mining, that has some of the most pain from getting broken, beaten for so long, we have some of the most painkillers. That these are inextricably tied together. And so when we're exposing that brokenness and that inequity through saying, oh my gosh, in our county, we've lost one person to an overdose every 3 days for 5 years. We're saying, let's look harder at that. Like the climate crisis makes us look more at racial injustice, or the racial injustice fight makes us look harder at the climate crisis. When things get so bad, they let us look at these other things. And I think if we do it right, I think if we respond to the overdose crisis and the HIV crisis right, instead of just giving out needles or just giving out PrEP, then we will actually get at the trauma and the inequities that drive all this drug use in the first place. And I think it's really hard. Still in West Virginia, when we talk about overdose prevention, we don't talk about addressing poverty. We don't talk about it, getting at classism as a way to get at overdoses. We don't talk about a living wage as overdose prevention, or paid sick leave as overdose prevention, or paying teachers a real salary as overdose prevention. But it is, and I think we'll get there, but I don't think we're there yet.
Thank you. Any other responses? And we've had some comments about just stigma in general.
I would say, so I'm also down here. I guess we all are down here in Appalachian area. That there's, combined with the fact that we have more pain because of the types of work that we do, and then the over prescribing of pain medicines. Here in Alabama, we have the highest pain medicines in the country. We have 107 prescriptions for every 100 person in the state of Alabama. So we have this overprescribing problem. But particularly in small towns in Appalachia, we also have this very religious background, that not that it's religions that are stigmatizing, but a lot of people then, oppose harm reduction measures based on moral standing. And that's what I'm dealing with the policy folks now, is I'm about to go find church people to write things that I can sell to because we can't keep bringing them science. They might ask for science, and at Schutz Senator Schutz is a great example. He said, show me some science. And we showed it to him. He said, show me more. And we showed it to him. And then he said, well, I just have a fundamental problem. We have to stop thinking that our values of science and harm reduction are going to convince someone who is driven by another set of belief systems. We have to figure out how to leverage their value system and make our mission fit into theirs.
Thank you. Any other comments? We have another question. Okay, so this is from Savannah Lyons, watching with Dr. Seitz. Dr. Schutz told a compelling story about how LGBTQ volunteers working on the front lines of AIDS treatment and prevention may have, in the long run, helped bolster public support for the LGBTQ community by sharing their knowledge with the broader community. How can we work together to tell a modern day story about harm reduction workers, both in mutual aid work and in public health spaces, that also shift how our society thinks about intravenous drug users as a whole? I think that's a wonderful question. So, who would like to go first?
I'm happy to take a stab at it, but I feel like
Okay.
Dr. Schutz and Dr. Stringer have more experience at this sort of historical and national landscape of people that have been fighting. So I can follow you guys if you want.
I'm happy to toss this one. I'm struggling to come up with an answer I'd love to have. If you have thoughts, I'd say go for it.
I can talk about drug use stigma all day long. As far as how can we get people involved, we have to acknowledge the facts. And so I don't know, I'm at Columbia University, which is where Carl Hart is. And I don't know if you guys saw the recent discussion about Carl Hart saying, I've been a heroin user for 5 years. He's also one of the most prestigious professors that we have. And I think that we need to start having honest discussions. And I think that it is so brave of Carl to come out and to say these things. And, even within research, so I have a lived experience of substance use disorders myself. And I know that there are, people like Carl Hart. He wouldn't say that he has a disorder, but he has lived experience of using. And I know other people who have too. And Carl Hart made a great point in that as research advocates, there's only so much we can advocate because we have to hold the line that the NIH holds, which is drugs are bad, drugs are bad, drugs are bad, which, drugs can be bad. And they can, I lost my father to an overdose. They can very much have a very negative impact, but we have to, start talking about, sometimes it feels good. I mean, if it didn't feel good at some point, we wouldn't have kept doing it. And I think we have to just start having open discussions. I would argue that Joe maybe has more experience on how to get loud and get proud, because I feel like we do have such a limited ability to do that from the academic space.
I don't know. You guys in academia are kind of rock stars. When we set up our big health fairs, the PhDs from WVU come on down and they give us big money. They give us research projects. They carry the day with awesome trainings and preaching at city council at our dingleberries. So big ups for academia that get in the trenches, and Dr. Robin Pellini, who's sort of our WVU rock star. You have Dr. Carl Hart, amazing. We have Dr. Robin Pellini. I don't think there's a lot of models of places that have organized drug user rights as if they were another era of civil rights. So when Dr. Carl Hart goes out and says, I use heroin, and gives TED Talks or whatever, and writes this amazing revelatory book, why does it sound so revelatory? Because so few people say that they use drugs publicly. It's sort of very much
so stigmatized.
So stigmatized. And yet there are models as rare as I wish they weren't, where people say, get loud and proud about it. Like, I'm just an advocate. I'm just a social worker, Jewish guy, plant in West Virginia, trying to make things happen. But in Vancouver, British Columbia, it's not a coincidence that they have respect for their drug user base. It's not a coincidence that they have supervised injection sites. It's not a coincidence that they can access a safe heroin supply with special vending machines. For the last 2 or 3 decades, active drug users, people actively using, got together with a few social worker types like us, or academics like us, and like everyone on this call, got together and one organizer, it's Ann Livingston, right? Like, set up flip chart paper and just said and offered spaghetti, and was like, they didn't, I guess, do as much pizza, and she had this flip chart paper, and she would say, all right, what do we need? And she would write down everyone's thoughts. And what was the first thing that came up out of that flip chart paper a couple decades ago? People said, we have nowhere to go. These back alleys, we're stabbing ourselves. The cops are rolling up on us. They're taking our stuff. We're getting beaten. We're dying. We have no space. They didn't say they needed a supervised injection site. They just said they needed space. And so what did they do? They rented a space together. They just got a corner. And it was the kind of space that had back rooms. And so before you knew it, people were using drugs in the back rooms, and if someone overdosed, someone in the front had the naloxone, and then what happened? The police walked in, and they were like, "Whoa! This is messed up." But we're somewhat diplomatic Canadian police, so we're going to say it like this: we don't condone it, but if you start dealing here, we're going to shut it down. So then, what did the drug users do? And the social worker types, they came the next day with baseball bats. And if someone started to deal, they took out their baseball bats and chased them out. The first supervised injection site in North America was run by drug users, by social worker types, and by baseball bats, and set the tone for years and decades of getting those rights in that metropolis, which then trickled out to the entire country up there, where the Supreme Court weighed in, and now those sites are legal in that country. Now that in that country, there's some respect. So I think it's messy.
Yeah.
You mentioned rights, and there was a quote that I pulled out for a presentation last week that, and I may not get it absolutely correctly, but there's very little discussion of drug users' rights. So within the human rights discussion, there's drug users are almost never mentioned, and in discussions around drug use and people who use drugs, there's almost never human rights mentioned. But the UNDOC, UN Department of Criminal, they look at criminal stuff. It's the UNDOC. They did release a document last year specifically on drug users' human rights.
I will say too that I felt like we were edging a little towards, at least with the opioid crisis specifically, a little towards perhaps a broader acceptance, until I think the marker was once Trump got elected and there was so much bandwidth given to all the political controversies, and then the pandemic hit, extending the bandwidth even further. I felt like there was a little bit of movement, not nearly enough, but we were starting, particularly because it seemed to be hitting some of those red states that might be more stigmatized or rigorous against talking about that. I was struck, I mean, the idea that a presidential nominee would stand up at the podium, that was Joe Biden in 2020, and declare to the public looking into the camera, well, my son had a drug problem, and many of you may know about that. And so that's essentially why we should excuse this issue and go forward. I mean, that,
well, he had to.
I can't imagine that happening, you know, maybe even in any other election prior to that one. Mm-hmm. So I feel like we've moved a little bit, and the pandemic especially, I think, perhaps has sort of curtailed any possible discussion of anything else. But maybe we would have made a little more movement on that. I don't know.
And thank you for sharing those resources, Joe. I'll make sure that when we share the video and stuff that we share those resources. And then we have another question from Tommy Schutz. And does anyone think there's possibly a space for destigmatizing drug users through the more recent push to legalize marijuana, particularly when expunging nonviolent drug convictions is part of marijuana legalization?
Go ahead.
No, I think I agree. And I think that's where we saw, for instance, like countries like Portugal and then states like Washington and, well, Washington, I'll let you go, but yes. But we saw those types of benefits.
I think it's, marijuana is such a different drug. I don't think that legalizing marijuana is going to destigmatize other drugs. It may be a space to open the conversation. Mm-hmm. I was going to say, like I said, I'm down here in the South and in Alabama, and so I'm even deeper red than you guys. And I thought, COVID has almost made us willing to legalize marijuana. Just last week, our governor signed a thing saying that we could have delivery alcohol. So I think some of the stress from this pandemic, and in some ways, I think it has helped to destigmatize. And this is what I have found talking to politicians around here, is that right now, people are realizing, number one, they're having a little bit more empathy for people who are losing their jobs. they're starting to be able to see themselves as the person that could be impacted by the drugs. So I think in some ways we may be a little more willing right now.
I will say, I think I agree that marijuana may be perceived, that basically what we've done with marijuana now is drop it into a quasi non-drug category, almost like what people say or had said before. That I noted the comment about Asian Americans being part of the, an example of how this epidemic has been similar sort of in sort of linking or preventing a proper response and so forth, which I think was a good point. And it almost reminds me of how, there's been some discussion about, are Asian Americans, could they even be lumped into the white category? And I feel sort of like we're kind of shifting the categories and moving marijuana into almost a non-drug category now. But I do think, and thus maybe it's not so promising for other drugs, but I do think that his other point about expunging nonviolent drug convictions is an important one. And of course, there was some movement by President Obama to do something about some of those federal convictions on drugs. That I think that is more promising.
Yeah, thank you. And then Joe responded as well. He says, I think there's a spot on opening there. In Dr. Hart's book, there are some reflections on that and the kind of hypocrisies that arise as we work to destigmatize some drugs without a more full spectrum analysis to legalize all drugs and end the war on drugs. I think, like Dr. Stringer's hinting at, the approach and the vision seems to matter. We also know more people die from alcohol every year than opioids. We have the push board we need to decriminalize heroin and other drugs. We have the supervised consumption sites for alcohol all around us. Yeah.
I think it's important to note that, we need to end the war on drug users. We're not saying we need to go hand out heroin to just, we're going to decriminalize it and you're going to go to your bar next Saturday and, order heroin. We need to decriminalize the drug user. And that's, I think there is a way to stop the negative impact. I mean, like I said, in Kazakhstan, it is the drug trafficking route. So it is actually the trafficking of the drugs that's really devastating that country. And so there is a way for us to address those type of issues, but those are much different. Drug trafficking is much different than someone who has a substance use disorder and a medical disorder that deserves compassion.
Joe, I saw you raise your hand.
I was trying to do the clappy thing.
Oh, okay.
To end the war on drug users. I had Dr. Stringer knocked that out of the park. And Dr. Perry, I was wondering, you said early on at this call that you were like, I got some ideas for Charleston.
Yes, no, definitely. And just because my master's in bioethics, and how I know Dr. Stringer is I also taught women's studies. Well, we'll pretend it was only 5 years ago, and we just but I've known Dr. Stringer for a very long time. She's a colleague and a good friend. And so I'm familiar with research, and I would love for you to attend a talk on Friday with Dr. Norman Weatherby. He's one of my former professors. He obtained what is called a certificate of confidentiality to work with undocumented farm workers who were also intravenous drug users. And so he was able to find a couple of sympathetic ears within the Miami Police Department, which, this is Miami, and he was doing this during the whole Miami Vice era as well. And he was like, look, we want to do this research. We're going to get a certificate of confidentiality we need your cooperation. So he was really able to make a difference that way. And also I wrote a note myself just on the activist parts of just my background and thinking, so the law that a $10,000 fine for per violation regarding harm reduction practices, those are considered best practices. And so I don't think that law is necessarily legal. And granted, I'm only half of a lawyer, but I think I have to say that, but I think you can find somebody, like either I wrote like a harm reduction organization or a legal organization saying we're ready to file suit against the state if the governor signs this.
Yeah, that'll be thrilling. We're a social type, so we're backed by the ACLU and another a fleet of lawyers, but who are already threatening that it's unconstitutional. But I like where your mind is at, and like, because my mind doesn't really know what it means to be unconstitutional. Like, I don't, or how to leverage the new CDC best practices from this past December. I don't know what that argument actually looks like, so I think I'd really be excited for your insights there.
Okay, yeah. So for me, it's the equivalent of a lot of institutions like universities put the I can't think of it, but it's like they like jumpstart the heart, but they're like little portable ones. I can't think of the specific medical name for them.
Keep trying with your hands.
Right. Yeah, it's like whatever that thing is. Yeah, that jumpstarts the heart. It would be the equivalent of making those illegal because they're considered best practices. They're making best practices that save people's lives illegal. And so
fun if we could sue them on that.
Yeah, and so if you can even equate that to even like, banning insulin for diabetics, because it's considered best practices.
Right. Did you all know that this little bit of trivia, the months before the American Disabilities Act was passed, there were two classes of people that were fought to be included. One was people with HIV and AIDS, and one was people who use drugs. And they were both fought tooth and nail by one senator, Senator Jesse Helms. And he was successful in stopping one of them.
Yeah.
People whose drugs were almost included in the ADA. And the compromise, which is completely awful, god awful, is that only people in recovery, God bless them, we need those people to be covered, are what's covered. So if you look at the ADA, you're like, how come people in recovery are included? Well, that's the genesis.
I got clean 20 years ago. And to this day, if I were to die with any alcohol, any drug in my system, my life insurance will not pay.
It's so messed up.
Yeah. And that's just, I think with what Chris brought up earlier with President Biden talking about, his son was a former drug user. I think might have a sympathetic ear to let's revisit the ADA and have,
yeah. I agree.
And Biden did release just this week his stance on, addressing the opioid epidemic. But I don't think that he came out and addressed it head on like that because he wasn't ashamed or because there was no stigma. I think because the stigma was so great. Because the other side kept saying, your son is this, your son is that.
Yeah.
He couldn't not address it. And I would like for it to get to a point where it can't be weaponized.
Completely.
Weaponized against him. And so it was more of a defense thing. But someone mentioned law enforcement, and I dropped a link in the chat. There is a law enforcement action partnership. And I've also spoken to, there's like a representative from Health Policy Legal Network that is assigned to the Southeast. And he said that in North Carolina, one of the things they were able to do was, if you can get, so I'm in Alabama where we do still treat marijuana like it's, some of the harder drugs. So we definitely don't treat it like it's alcohol here. So getting harm reduction things passed here are very difficult. But if you can get, even in a red Republican super majority, if you can get the police to back you and, at least one Republican senator, you can still make those. And as much as I want to go, I mean, Tara can speak to, I tend to have a, to me, and I just like go out and scream at the top of my lungs. But what I've been learning is that I have to be nice. I have to find that, okay, well, what is it that you value, and how can we make this bill in a way that doesn't compromise its effectiveness for what we're trying to do, but is more palatable to you. And some of the selling points for police is that, syringe, we're trying to get the syringe exchange passed. So that's what's on the top of my mind, is that, there's actually, you have a lower chance of a job-related needle stick when syringes are decriminalized. So there, we have to work at reframing, and I have to work at being nicer. And I am.
And I think what Dr. Stringer points out is like when we don't have a flood of people in front of us, next to us, behind us, all around us, that are actively, whose lives are on the line, we have to be really nice. We have to figure out what accent we're going to use. We have to put on our suits and ties. We can't dress like this hoodie, and we can't yell. But when we have a real movement, just like any other civil rights movement, whether it's suffragettes, whether it's LGBTQ, whether it's, of course, African-American civil rights, whether it's ACT UP fighting for folks with HIV and AIDS, then you can get a little rowdy. But because we don't have that many models in recent years of organizing with drug users, we're often reduced to lobbying, which is the thing you do when you don't have leverage. And you can do a lot. You can get really lucky, especially if you're
that's exactly the space I'm in.
Yeah. And it's where most of us are at. But it's just worth reminding ourselves, especially as we probably got some young organizers on this call, that if you can get close to the pain, if you can fill your backpack with naloxone, and you can write down every idea that someone has, you can get to that place that they got to in Vancouver and the other places are getting to. I mean, there's drug user unions in North Carolina that are not too far from us that have also shown a similar kind of momentum. I think North Carolina, their law is like 2 or 3 years that says their syringe access law says it's wild. It says not just that they're legal. It says every program should give out enough syringes to the individual that they have a clean syringe for every injection.
I think that they're looking at trying to get stuff overturned in North Carolina right now too.
Yeah, they're going bat wild to overturn that. But it is a standing law. Virginia has something somewhat similar. The American Medical Association has then looked at North Carolina and made it their model bill. And it comes from building power.
Well, I'm glad that we were able to bring everyone together and have this conversation. And hopefully, maybe we can have some continued partnerships. So is that a clap or is that like a hand raise? Like project? Okay. See, I'm just learning this stuff. So I thought people were raising their hands to talk, but yes, I'm also clapping. We should definitely stay in touch and try to, I would love to be able to visit West Virginia and help with some organizing, especially during the summer. We have some time. And I definitely want you to come and speak to my classes. However, whatever safe way to do that in the fall would be. Sure. So
I could visit Jack.
Yes, exactly.
And then Dr. Stringer could come into town because it turns out that both of you have a lot of experience with Kazakhstan.
I know that's interesting. Yeah.
That is not something I find a commonality with people.
Yeah, Dr. Seitz did a presentation on cholera in Kazakhstan on Monday. So
interesting.
Yeah.
So Dr. Schutz, if you can somehow go to Kazakhstan, this summer, then we can all get together in August and just chat about that.
Yeah.
You ever had Kazakhstan
Let's put something together. Yeah.
My wife has been talking about a vacation after the pandemic is over, and this really might fit the bill. So
Yeah. I can do some public health stuff there. I can turn it into like a study abroad.
There you go.
Yeah.
I could hook you up with the Global Health Research Center.
Well, there you go.
When some of those countries, their meth issue is so large that it's harder to save lives because naloxone doesn't work. And so if you think we have it bad,
and that's where we're headed right now too.
Yeah.
From the data perspective, we saw the opioid epidemic coming, the heroin epidemic after the opioid epidemic, and where we know that the next wave is going to be overdoses from stimulants because the fentanyl is in everything.
Which is another way of saying these are the last years we have to save the most lives.
Mm-hmm. Wow. Well, I think that's a wonderful note to end on. So thank you. I've actually got a little emotional with that. So thank you. Hope everyone have a wonderful night. I'm sure my dog is like, just please come home and let me out. So it's nice to meet you, Savannah. I've heard wonderful things.
And I do apologize for being late again.
No, it's fine. I still I haven't lived in Middle Tennessee in like 4 years, and I still get confused with Central and Eastern time. It just happens. So, well, thanks everyone. Have a great night.
I think Jack's home is just as dark as his office. He just seems to be a kind of, which goes with, as I've told him, his very dark personality.
So my son bought me a ring light for Christmas, which I think he thought I would do something fun with it, like take selfies, but I use it for Zoom.
Oh, nice. Well, I realized that my office looked like a horrible mess with our myths on vaccinations video. I can send it to you, Kristi, and you'll laugh. I try to organize as much as I could, and I'm just like, that was the first thing I noticed, that I had forgot to put up stuff, and I'm talking about myth vaccines and but it's the end of the semester.
It's our homes. It's our homes. Bye, guys.
Bye. Thanks.
Wonderful.